My name is Jessica Sparks. I'm a nurse. I work in Lexington, Kentucky. I graduated with my ADN in 2013. The hospital that I work at is a 433-bed hospital. We offer a wide variety of services, and we house 4 ICUs. And this is also where I decided to do my practicum. I began my practicum working with our critical care clinical specialist. In October 2015, she began a project to try to get our charting system, which is Cerner, to include an ICU liberation tab to help remind nurses about things like delirium development in an ICU. More information was needed on delirium and the interventions needed to reduce the presence of it and to reduce the time that someone may experience delirium. And this is what I decided to do as my goal of my practicum. So some might ask, why delirium? Well, I spend all my time on my practicum focusing on delirium. Delirium itself is a disturbance in the mental abilities that's often characterized by several things, including an altered consciousness and cognition, and often confused thinking and a decreased awareness of one's surroundings. It could also include impaired attention and sometimes even disorganized thinking. When this is developed by someone in an ICU, it can lead to a lot of things, including an increased risk of mortality, a prolonged ICU stay, and poor physical and cognitive outcomes. As nurses in an ICU, we often overlook things like this because we focus on things like blood pressure, heart rate, oxygen saturation, and urine output. But delirium is also important. It involves the brain, which is a vital organ. The prevalence of delirium in an ICU is pretty outstanding. It is estimated that 60 to 80% of mechanically ventilated patients in an ICU develop delirium. And then 20 to 50% of patients that are not mechanically ventilated are going to develop some delirium. There are several risk factors that are going to increase someone's likelihood to develop delirium other than just being on a ventilator. And those include pre-existing conditions like Alzheimer's or dementia, hypertension, an alcohol history, high severity of illness, and benzodiazepine usage. For our practicum project, we had to develop several learning objectives and decide how we would meet them throughout the course of the class. So the first one that I came up with was to identify an evidence-based practice tool that could be used for the delirium assessment in the ICU. And then I came up with the CAM-ICU tool through my research and then also through seeing which tool would be most nurse-friendly. And this one actually takes less than 1 minute to complete. On the next slide is a depiction of the CAM-ICU flow sheet. I'll walk you all through it. As seen in the picture, to complete this screening, you assess if the patient has a change in their baseline mental state, or if it has fluctuated in the last 24 hours. If the answer is no, their screening is negative. Simple as that, less than 1 minute. Move on to the next thing. But if the answer is yes, you move on to the next question and ask them to squeeze your hand when you say A, when you spell save a heart. SAVEAHAART. If they have less than 2 errors, it's negative. But if they have greater than 2, you move on to the next step and gather their RAS score or their level of consciousness. If it's something other than 0, they are positive. Or if they scored a 0, meaning they're alert oriented, you move on to the last step to see if they have disorganized thinking. And to do that, you ask them various questions. If they have greater than 1 error, then they are CAM-ICU positive and delirium is present. It's very important that this is assessed routinely in an ICU, as it goes undetected in 3 out of 4. My second objective was to assess the use of the CAM-ICU tool in the critical care units at my practicum site by actually asking the nurses to use it. I found that the majority of nurses charted the CAM-ICU once a shift. That's what we're required to do. But they don't know how to correctly do it. There are many barriers to the CAM-ICU because many nurses do not adequately know how to perform this assessment or what to do if their patient actually has an altered mental status or fluctuation within the past 24 hours. Some of the nurses also thought that the assessment could not adequately be done if the patient was mechanically ventilated, when that is actually one of the most important times to administer the assessment because they're at such a high risk of developing a form of ICU delirium. I believe that our charting system, Cerner, also has several barriers because there's nowhere to chart the preventative strategies like clustered care at night or promoting sleep, having the lights dim at night, bright during the day, and things like that. The nurse taking care of the patient in the Cerner system just simply says yes, KMICU positive or negative, and there's no criteria listed as seen in the next slide, which is actually a screenshot of the KMICU assessment in our Cerner system. My last objective was to develop an interventional toolkit that would be at a low cost for delirium prevention in the ICU. There are a lot of recommendations that I found through research to prevent delirium and reduce its duration. They included things like controlling pain and agitation, cluster care at night, and retime certain things. Like we do labs at 4 o'clock in the morning and chest x-rays at 6. For someone that's awake, there's no point in doing that when the doctors don't round until later in the morning. You can also turn the lights on during the day and open the windows, and then close the blinds at night and dim the lights to maintain a dimmer light environment, and then try to control the noise, have some quiet time so people don't develop delirium as much as they do now. For the toolkit, I thought it would be beneficial to have every patient that enters the ICU receive a set of earplugs to help drown out some of the noise, and then one of the sleep masks so that way they can drown out some of the light and help them sleep. Thinking back through our practicum and then looking back through the journal notes about what I had kept track of, what I found was interesting throughout the different modules, there were several things that I thought were evident and very noticeable that took place in my practicum site. In the first module, we discussed healthy work environments, and a huge issue that was brought up was the nursing shortage. The Journal of Nursing Management discussed the nursing shortage and how the shortage affects the patient-centered care. It was obvious in the different units at my practicum site that the units were short-staffed. There were ICU nurses that had more than 2 patients. Due to the shortage and high demand workload, it becomes apparent that the nurses aren't able to spend as much time with the patients, and therefore how would they notice a change in the mental status as quickly as they would if they didn't have such a heavy workload. Second, we talked about communication throughout the entire course, I felt like. It was also discussed in the Team Steps article that no more than one person can communicate without effective communication. It sounds so simple, but there's such a lack of communication in the healthcare field. If the team members cannot communicate effectively, it ends up affecting the patient's prognosis and their outcome. Team members should be able to talk openly about their concerns, their findings with other members of the team, since team members have the same goal, the patient. At my practicum, I set in on several roundings in the units, and they all use the same rounding tool, which is on the next slide. They talked through the sheet with the same goal and objective, being the patient and what changes could be made for the patient to have the best outcome. As evident in this sheet, the rounds cover multiple aspects of patient care, and in the neuro section, it mentions the KMICU and gives nursing care for the patient, and gives the nurse caring for the patient the option to mark the patient as KMICU positive or KMICU negative, which would be evident in them having delirium or not having delirium. Next, it kind of ties into the communication and the rounds that I set in on. The interprofessional teamwork was noted in my practicum in the roundings with the multidisciplinary team members. The rounds consist of physicians, nurses, physical therapy, case management, pharmacy, dietary. Anybody actually that was there that wanted to set in on it that actually cared for the patient in some way. During the rounds, we talked through the sheets and everybody voiced their opinions and communicated really well from what I had seen. We round twice a week with a critical care intensivist, and then we're also going to start rounding 3 days a week with the critical care intensivist, physician assistants, and the nurse practitioners. During the rounds, we all shared a clear purpose with the patient's outcome being the goal, and the goal of the rounding is to end up with the patient receiving better care. Lastly, the thing that I thought related well to what we learned in class to what I noticed in my practicum was information technology. It's such an important aspect of healthcare delivery, and it is really up the ante, I would say, for the delivery of healthcare that we're able to give. Electronic health records or electronic charting has really helped with the overall quality of care that patients receive. It gives the care providers the ability to look at test results, evaluations, orders, and other information when they're not even in the same unit that the patient's in. They're able to develop their plan without ever laying eyes on the patient, and that can be beneficial for them, seeing as they're caring for more patients than nurses ever thought about caring for. This is core for evidence-based decision-making, continuity of care, and patient safety. The electronic health record provides assessments, actions, and evaluations for a life trajectory. Every team member that I had saturation and doing their assessment so that other members of the team could see it, and therefore how the patient's going to receive the best. The American College of Critical Care Medicine developed guidelines for pain, agitation, and delirium in 2013. These guidelines stated that a valid and reliable monitoring tool be used to assess the development of the delirium, like the PMICU, which I've done my practicum study on. The best practice, as found in my research, is to perform the delirium assessment like the PMICU once a shift and as needed. If the patient has a change, then the assessment should be performed. And that is currently what we are doing at my practicum site and my workplace. After completing my practicum and reflecting back on it, it's really amazing to me to see how much effort is actually put into developing the best practice standards for critical care units. The critical care clinical specialist that I was working with had so many different projects that she was working on, and it seemed to be hard for her to find nurses that are actually at the bedside to implement them so she could see how effective they actually were. And I also found out how important assessing delirium is. I completely agree with the statement that was made during the presentation that as an ICU nurse, we focus more on blood pressure or your oxygen saturation, the medication, the drips that you're on, and different things like that, and not so much of your mental status. That comes next after all of those things that we see as sustaining life. But delirium should also be accounted for, and it should be assessed after finding out how much of an impact it actually has on the patient's long-term prognosis. After doing this, I've actually joined the ICU Liberation team at my hospital, which is also my practicum site, and we meet twice weekly, and we kind of go over the projects that my clip spec is doing and helping her develop new practices and new pilots to do to kind of develop the best practices for our hospital to start doing. And I've also started a CCU project, which is my home unit on delirium, and I'm looking at the different patients that were admitted in June. For example, we had 80 patients that were admitted to CCU in June in 2016, and of those there were 14 that I've identified as being PMICU positive. And with 3 out of 4 going undetected, there's really no telling how many actually were PMICU positive that just weren't documented correctly. From doing this, I'm going to look at the different medications that they were on and see if there were any similarities, and then see if maybe a room number, if they didn't have a window, if they didn't have a critical care intensivist on board, different things like that, different conditions that they came in with and the severity of illness. If there are any other things that we can identify as giving people a higher risk for developing delirium,